Over the Wall provide free camps to children that have got health conditions. We provide family camps for weekends. We are at the back on the orange table. Hoya's waving at us. I know lots of you have heard of Over the Wall, have been to Over the Wall, but it's completely free. They are usually in holiday times, but come and speak to us and let us tell you all about how amazing Over the Wall is. Thank you.
Can vouch for that. Incredible trips, incredible opportunities. Okay, so now am I allowed to yeah, okay, fine. Now it's time to introduce this panel of experts. Thank you. All good? Thank you so much for giving up your time today. I would just say this is an opportunity to ask absolutely anything you've ever wondered, been afraid to ask, or just pops into your mind today. I guarantee there is no such thing as a silly question, and I promise you, if you're thinking it, somebody else is thinking it. If you're wanting to ask, somebody else is wanting to ask, but maybe not having the confidence to. So please, feel free. We've got somebody walking around with a mic, so just stick hands up. And I'm just going to ask the panel to introduce themselves so you know who we all are. My name's Andrea. I'm a children's doctor from University College Hospital, and I look after children with red cell disorders there.
Thank you. I'm Martin. I work in Cambridge. I'm an adult consultant. I mostly look after people with sickle cell. Sorry, louder. Oh, sorry. So my name's Martin. I work in Cambridge. I'm an adult doctor for sickle cell and thalassemia.
Hello, my name's Roanna, and I'm from the UK Thalassemia Society.
You need to keep it quite clear.
Okay.
Yeah, sorry.
Can everybody hear me now? My background is as a practitioner psychologist, and I trained in sickle cell, but I also live with thalassemia myself. So I'm happy to speak to anybody later.
Hi, I'm Noemi Roy. I'm a doctor from Oxford, and I look after people with sickle cell disease, thalassemia, and rare inherited anemias.
I'm Kofi. I'm a psychologist. I work in Northwest London, and I work with children and adults with sickle cell, thalassemia, and rare anemias.
Hi everybody, I'm Nneka Smith. I'm a patient advocate. I live with sickle cell. I've got hemoglobin SC, but I also work for the NHS as well, so do lots of work to ensure where I work is inclusive and supports patients through their, particularly teenagers, through their transition, and making sure we sign up to some of the trials and the things that are happening in the sickle cell space.
Thank you. My name's Ben Carpenter. I'm an adolescent and adult transplant doctor. I work just down the road at UCLH, and so I look after people who are having transplants for all sorts of conditions, but also for sickle cell and thalassemia, and also have worked on some of the gene therapy and gene editing studies.
It's my turn. Yeah. Hi, so my name's Chris. I'm the paediatric red cell nurse specialist. I've got a little supporter out there. I can see him clapping. I'm the paediatric red cell nurse specialist at UCLH, and I also work for the Red Cell Network in education.
Hello everybody, I'm Janine Younis. I'm a paediatrician at the Whittington Hospital. I specialise in looking after children and young people with sickle cell, thalassemia and rare anemias.
Can you hear me?
Questions for the panel? Come on, baby. Oh, yeah.
So, enter the mic.
Feel free to say who you want to ask, otherwise ask the question and we'll direct.
Hello, my name is Cordelia. My question goes to the transplant doctor. My son had a transplant August 2022, and just here right now, I was having a chat with somebody and this question came up. Transplant is successful. What is his genotype now? His donor was AA. Or his donor is AA, sorry.
So what hemoglobin would he now be making is the question, is that right?
Yes.
So it slightly depends, because it depends on who your donor is. There are obviously the possibility that your donor has trait, and so if your donor just makes all of adult hemoglobin, sort of normal hemoglobin as it were, then you would potentially switch to predominantly making just normal hemoglobin A. If your donor has a sickle trait or a trait of another condition, then you will follow that pattern as well. And so there are lots of people who have a donor who has sickle trait, and then they would make maybe 30% S hemoglobin still. So after the transplant, sometimes we notice that the S percentage is coming back up again, but then normally it would settle out at about that sort of trait level of around 30. And obviously it would reflect whoever your donor is, ideally. It can be a little bit more complicated than that, dependent on what type of transplant you've had. So if you've had a full intensity transplant, then you're more likely to have very high level of only donor cells in your bone marrow, and therefore the blood that you make. If you have maybe a less intensive transplant, then there may be a little bit of more of a balance of the new donor cells, but also maybe some of your old cells as well. So there can be a little bit variations on the theme, but largely it will track who your donor is. Does that make sense? Yeah.
Reproduction, sometimes they forget.
Okay, and so yes, so a good prompt is that the cells that you are transplanting are only hematopoietic stem cells, they're only blood cells, so it's the only system in your body that you're actually changing is your bone marrow. You're not changing any other cells in your body, so thinking about in the future your children having children, for example, that nothing changes in terms of the eggs and sperm that are made. So in terms of the potential of passing on the genes, whether you have sickle or thalassemia, that still needs to be considered when someone wants to go on and start a family. So I think that's a really good point. We're only changing the bone marrow, we're not doing anything to anything else in terms of cells in the rest of the body. Yeah.
We're just getting some feedback here that it's actually very loud. We've got a lot of noise coming from the back of the room, which I think is making it harder for people to hear here. I just wonder if while we're doing the panel, people might be able to come and join us, or if we could maybe try and keep the noise down a tiny bit down that end, that would be super helpful. Okay, next question. Who's got questions?
As close to the mic as possible.
Hi, this is a question addressed for the psychologists that are sitting there. In terms of with children with thalassemia or even sickle cell, how do we ensure or help those patients or families to kind of work around when it comes to emotional support? Because I think a lot of it is, when it comes to the emotional side, I feel like it's not as addressed, and it's something that I think families or patients have to kind of work around as children are growing or going through it. How do we start? What's the starting point? And as children grow and you go through experiences, how do we work then with perhaps with schools or even with hospitals? What's the starting point?
So ideally, as you know, all the conditions are lifelong. So ideally, as early as possible. Unfortunately, it appears that in terms of funding and resources and having psychologists working as part of the multidisciplinary teams that look after children with, let's say, sickle cell, thalassemia, or rare anemias, we don't have enough. So what we've tried to do is at least have some guidelines and looking at, let's say, the quality standards that we use for peer review. We have defined that as being at least one person working full-time as a psychologist with 300 patients. But as we know, we don't have that equitable distribution of psychologists. So what I would say is that as much as possible, we have to start, as early as possible, working with children and families. If you take sickle cell, for example, children have the possibility of having strokes or neurological complications, what we call silent strokes or whatever, early in life. They need to be assessed in terms of their cognitive abilities and providing the support through the schools to make sure that they can achieve. But looking overall, also, thalassemia patients, rare anemias, everybody has emotional challenges, but sometimes even in terms of the treatment. So if you're, for example, having transfusion-dependent, people, sometimes, just being able to manage transfusions with the iron overload, it becomes challenging. So what I would say is that as much as possible, we should be able to start as early as possible, working with schools as much as we can, making sure that they get the right support. And when they get to teenage years, that is also challenging. We need to address the educational side of things, making sure that the parents can give them the support, but we as the health professionals and psychologists or whatever, making sure that they understand their condition. And so it's a lifelong thing, and when they get into adulthood, the issues still remain. But unfortunately, as I said before, the support is not enough, and we need to try and make a better case in terms of NHS England or whoever our funders are locally as well to try and address these.
I'm just going to add, as an ex-educator but also somebody with sickle, one of the things that I think we forget is holistic approach to care. And what I mean is the rounded approach to care. So when you're talking about schools and things, it's about dispelling a lot of myths. So your children can play sport within their abilities and capabilities. And the impact of playing sport and the impact of doing music and art and drama also helps with their ability to process emotions, deal with their feelings. So utilising those aspects as well. And then you've got other things like, do they see adults living out there with sickle cell and what their journey is? Do they know that there isn't just one pathway, that you can take different routes around with your care, but also with your education and training and development?
Can I just add one more point?
Thank you. I was just going to have one comment and then one question for Roanna, if that's okay, and then you want to come in anyway. So I would say that psychology has a huge gap, certainly within our service at UCLH, and I recognise that. I would implore you all, the patient voice is loud, so please use it. Take your voice to the trusts, put it in writing. We as clinical teams will facilitate those messages, but your voices are loud, so please use them. Tell us what the gaps are, what you feel that you need, what needs to be done better, and we will try and advocate as much as we can in terms of getting that support that you need. I'm just going to ask Roanna, I wanted to ask Roanna, and then we'll come back to you. So Roanna, I suppose my question was, what, if you're happy to talk about it, where do you feel you would have perhaps benefited psychologically, or either from that support, or what were they some of the impacts? Any advice you can give to our families and young people living with these conditions?
So I think psychology needs to be part of the program from the time parents are given the diagnosis, because one thing is that children learn how to cope with the condition based on how you approach it. Because we're born with these conditions, we've not learned how to deal with it. So I think parents need to be supported. I think, and I say this all the time, but I think parents have it a little bit harder, because when you're sick and you're dealing with it is one thing, but watching your child go through all of these journeys must be very difficult. So I'm only a parent to rabbit, so I can't talk for children. But I think it's really difficult. I think having children and seeing psychologists play as young as possible is helpful. So you learn, because as you get older, I can tell you, When we see people with needle phobias, it tends to be in their 20s, 30s, 40s because of the trauma they've endured their whole lives. Whereas the 7-year-olds will readily hand them, you know, and be like, I want to be stuck here. So I think it's trying to teach them that the resilience is within them and how to channel that. My word of advice here is the Thalassemia Society is around. We can put you in touch with lots of other parents who have just gone through that, parents who have had children just slightly older than you. I have a little star, Theo over here, who's a football, my football star. And it's kind of linking in with other families too, because you learn from each other. And also we can help mentor you, tell you what to expect at each time, you know, and give you some advice because we've gone through it. I can tell you all the bad I've done as a child with not taking meds. But we're there, so please get in touch with the society. I know you guys are, but please do because we can help.
Thank you. Okay, next question.
Hi, no, it's not really a question. It was just to add to what this lovely lady said about linking in and meeting adults that have had the same condition. So I don't know if people know, but we have a sickle cell peer mentoring program where we do match adults and children and young people so they can see what their life might be like, what to expect, and ask those questions that are really important, especially when it comes to transition, especially when it comes to growing up through adulthood, what to expect. And it's again linking families in with what the expectation is and having that community. So I just wanted to touch on something that was said earlier, because I think it's really important actually, having that community and being in touch with people who are experiencing exactly the same thing that you are. We're on the stall just at the front, so if you want to have a chat with me, I'm happy to have a chat.
Thanks, Odessa. Thank you. So Stuart, I think you've got a few questions. There's hands up there. Stuart, you've got a...
Good morning, everyone. My question is, I read an article on the maybe news or something like that. It's in America, which it says that kids with sickle cell, that they can change their blood genotype. I don't know if that's possible, like from red blood cell, they can kind of put some blood transfusion in them that will change it from SS to maybe AA or AS. I don't know if that is possible because I've got a boy of 9. Each time he's in pain, I always feel for him. And although I've got people that can help me from King's College because that is where we go in and out if there's anything. But still within, it may be pains, things like that, which as a parent, there's nothing you can do about it. So I don't know if there's a way, like a research that will kind of help out, because putting it in an article, I think they've already kind of make a kind of research on it. So I don't know if it's possible in UK here, but the article I think is from America or something like that. The little boy, the SS was kind of changed and he has AA. I don't know if that's possible. Thank you.
Okay, so I think this is a question for Ben, but I wonder whether there's also something we can touch on after thinking about managing pain, and we might look to the panel for who might like to come in on that. I honestly cannot imagine as a parent how distressing it must be to watch your child in such terrible pain, and yeah, maybe we can think about that a bit together. So Ben first.
Thanks very much. So in terms of the curative therapy options, both if you think about transfusion-dependent thalassemia and also sickle cell, the options that we have at the moment are a donor bone marrow transplant. I know that's not quite what you're saying, but that's taking someone else's cells who's suitably matched to you, having treatment to wipe out the current bone marrow cells and then giving those donor bone marrow cells to then start producing normal hemoglobin A. But what you can also do is take someone's own stem cells and make changes, which is what I think you're saying. And there's a number of different ways that you can do that. There is gene therapy, and you might have heard of a company called Bluebird Biotech, and so that's using a virus to introduce a new gene into someone's own stem cells to then give them back. But what we can also do now is gene editing, and that's something that you might have heard about in the news and has been approved by NICE for thalassemia. We've had another meeting very recently, and it's under appraisal from a sickle point of view, and we're hopeful, and we probably will hear some more news over the next month whether that's available. These things still do involve a bone marrow transplant, and they are quite intensive therapies. What the gene editing approach does is it switches on the hemoglobin, back on the hemoglobin that we make in the womb, fetal hemoglobin, and that's how it works, by switching on the cell's button that allows them to start making fetal hemoglobin again. And so you can either take donor stem cells and give them to somebody, or you can make changes. What you might have been reading about is that in the future we might be able to make even smarter changes to someone's genetic code and actually just make just very fine changes to the genetic code, so people make different types of hemoglobin that don't give you the symptoms of sickle cell. And so that might be what you're reading about, but at the moment we have donor bone marrow transplant and gene editing for thalassemia, and hopefully gene editing for sickle cell is what we've got at the moment. For donor transplant, if you are less than 19, pretty much all of the donor options are on the table, but both for thalassemia and sickle, in adulthood you need to have a fully matched sibling, brother or sister donor, which most people have got about a 15, maybe 20% chance, if you're lucky, of having. So that's why using someone's own cells and doing things like gene editing or other change is attractive, because hopefully we can do that then for a lot more people, as long as we assess that someone's fit enough to go through that procedure. So I think it's my one plea on all of this is I as a transplant doctor know that these are not therapies for everybody. There are pros and cons to them, but I think it's really important that at least it gets considered in the round of the treatments that people are offered. The answer may be no, that's not for us, that's not for me, you've decided as a family, but I think everyone should have the consideration, could this be something useful for you? And it may be yes, we want to know a little bit more, but it may be no, thank you very much. But I think it's an important part of routine considerations.
Thank you, Ben. And just briefly, one question. What about other non-thalassemia rare inherited anemias and eligibility for transplant?
Did you have anything particularly in mind, or in terms?
GBA maybe?
Well, we can consider bone marrow transplant and a number of other conditions as well. I'm certainly not an expert in that. I don't know, Amy might be able to speak to that a little bit better than me.
So there's no gene editing or gene therapies for those, but bone marrow transplants for all transfusion-dependent anemias is a possibility. Some there's a little bit of experience with, some there's a lot more experience with, so it's by case basis, really.
So I think we'll continue, but maybe there are quite a lot of questions from the crowd which I'm keen to get through, but I would really like to think, if we can and we have time, about the comment you made about feeling as a parent as though you don't know what to do and there's nothing you can do when your child's in pain, and whether we could maybe come back to the panel to think about that bit. So.
Good morning. I'm a bit of a water baby, and I know that when we go on holiday, take the children, they've got sickle cell, it's somewhat worrying to take them into the water and, you know, at risk of them getting a crisis. So I was wondering if you had any other tips that we could use so we can all enjoy the water a bit more and not worry about it so much.
Great question, very common question that we get asked in clinic actually. Who, Chris, Janine, does anybody want to come in on that? Yeah? Okay. And then Nneka.
It's just the microphone. I'll speak after.
Okay. So the general rules, tips and hints that we have for that kind of thing is, if it's going to be in a hotel pool, for example, if the pool's heated, generally that's okay. Just make sure that you dry off really quickly afterwards and keep yourself nice and warm. If it's not heated, you can still... If it's not heated, then as long as you keep moving, generally you're creating enough body heat to try to give you a degree of protection. When you're going in the sea, obviously we can't really control that. So if it's really a hot climate, for example, and the sea's had time to warm up, it should be okay. But generally with the sea, it might be worth buying like a wetsuit or skins or whatever they call them nowadays, and make sure you're nice and dry afterwards.
There are lots of the wearable towels that you put over your head. They've got a little hood. They're really good. They dry you very quickly and they give you the warmth. But the most important thing is to know how your child responds to temperature difference. Once you know that, and you know the temperature of the sea, you know whether you're going to need that big hood wrap or whether you're just going to need a basic towel or whatever else. So it's about knowing what the temperature difference and the response to that, but also knowing your child and how they're feeling that day. Because if they're already looking like they're a little bit sore, a little bit achy, their response will be very different to when they're not so much.
I'll come on to Janine in a sec. The other thing I would just say is we would absolutely encourage you to encourage your children to live their life to the fullest. We expect and hope that we can keep you healthy. Our aim in the children's clinic is definitely about reaching your potential, doing everything that you feel you can. It is very individual, and we have lots of children that swim completely happily and it never triggers any sickling and they're absolutely fine. Unfortunately, there are some children who will be more sort of sensitive to heat and cold, and in a way it's trial and error, and that's tricky because of course you don't want to trigger a crisis in your child, of course you don't, but you want them to experience things. So maybe when you're starting out, you look at those environmental things that might make it more likely to be a success. I mean, I say things like have a hot chocolate ready after. This is completely anecdotal, seems ridiculous, but as a mum, I'm like, okay, have some hot chocolate, get your towel wrapped up, get you dried, get the wet towel off, get you into a warm, dry towel and see how it goes. The other thing I would say, disease-modifying drugs make a massive difference in terms of what your children will be able to tolerate and with the lives that they can live. So if you're not already on therapies like hydroxycarbamide and